Primary diagnosis should always be colon cancer until proven otherwise, but you do have the volvuluses, like we talked about with the sigmoid colon, volvulin twisting on itself. If they've had prior surgery and then we've released some of their other colon bits from the retroperitoneal space, we don't tack that back down to the peritoneum, so it would potentially become floppy. Okay, so it could, there are other parts that it could volvulus on itself, okay? But most of the time it's going to be the cecum or the sigmoid that twists on itself. Abscesses, right? If you've had a perforated appendix, diverticulitis, you look for that history of leukocytosis. Does the history fit? Right? If they've had a previous, appendicitis that has perforated, in a 20-year-old kid, that probably is going to be your first diagnosis over colon cancer. Right? Look for those things that are the most common. Hirschsprungs, more so in kids. Remember that 2-2-2 rule, right? Kids of 2 years, 2 feet from the ileum, and what's the third 2? 2%. That one. Say louder. 2%. Sure. I'm not a pediatrician. I've never seen Hirschsprungs because I rarely do kids. I rarely see kids. If kids come see me, it's a bad day for them. But massive amounts. Remember what Hirschsprung's is. It's that peristalsis, basically that missing that neurological ability to empty the colon. So they have massive stool burden. We call them FOS. Stool of S. Okay? So massive amounts, dilated colon, almost to the point of like a megacolon. Okay? You don't normally see a megacolon in a 2-year-old. Okay? So if you see a very dilated stool burden colon in a 2-year-old or a young child, you got to think of Hirschsprung's. Okay? Surgical correction is absolutely required, and mostly it'll be a pediatric surgeon. All right. Colon obstruction, so UC versus Crohn's. I will say I ask this every semester. Okay, you guys have to be able to know the difference between UC and Crohn's. This is not the first time you've seen this, not the first time you've read about this, right? UC, colitis, only involves the colon. Okay, it is mucosal inflammation. Granulomas are not present. Tissue pathology, they're going to do that colonoscopy, they're going to take that biopsy. Granulomas are not present, unlike Crohn's, right? Mouth to anus. You are going to have non-caseating granulomas, okay? You're going to have those ulcers, bear claw-like tissue. You're going to have islands of normal tissue between those ulcers. You're going to have more fistula connections, strictures, abscesses, just because the entire gastrointestinal tract is just so inflamed, okay? Chronically inflamed, right? So UC, you have a colon, only the colon, and you do not have any granulomas. Crohn's, you have non-caseating granulomas. I ask this every semester. All right. So with UC, okay, so colitis, pain, normally is on defecation. When they're actually having the bowel movement is when they normally have pain. Okay, especially in males, they're gonna have that proctitis. Okay, bloody stools more commonly found in UC. Also mucousy stools. So asking those really disgusting type questions: is there blood? Is there mucus? What does it look like? Take pictures for me. I want to see what it actually looks like. Okay, it's gross. They're going to be like, no, but if I don't see it, if I don't understand what actually is exiting their body, sometimes we just don't know what actually is happening. Both do have some extra intestinal type manifestations, skin lesions, arthropathies, osteopenia, basically because your body is malnourished. It's not getting all of the things that your colon and your GI tract are supposed to do, right? It's a disease that, like malabsorption type deals. But when we're talking about Crohn's, you're gonna have those mouth ulcers. You're gonna have dysphagia to the upper GI ulcerations. You're gonna have fistulas, okay, abscesses. So if you have ulcers other places than just your colon, you have to start thinking about Crohn's. Up to 70% of IBD patients require surgery. More so for Crohn's versus UC because of just where the ulcerations are. Because they have more abscesses, more fistulas, more types of like worsening extra intestinal type symptoms. But UC is curative if we do a total proctocolectomy. Okay, so taking the rectum all the way to the cecum, the entire colon is taken out. Okay, most of the time they're left with an ileostomy, and it is a permanent ileostomy. Okay, but we can cure it if we remove the problem organ. All right, which of the following most common causes of colon obstruction? Who says C? Everybody's hand should be up. Anybody disagree with C? All right, moving on. Hemorrhoids. Okay, hemorrhoids are the big problem, big pain in the ass, so to speak. Right? You have hemorrhoidal cushions. If you remember, you have a right anterior, right posterior, and then left lateral. Okay, those are where the hemorrhoidal tissue begin, and those are where your vasculature is. Okay. Further divided into internal versus external, and it all is relative to the dentate line. Okay. External, you're having distal to the dentate line. Internal is above. Internal, you'll have that columnar mucosal epithelium. Viscerally innervated. You can do some office treatments like banding. But if it gets to the point where you need surgery and do like hemorrhoidectomies, then we need to go to the OR. External hemorrhoids, most likely these are what's going to when you have like a thrombosed hemorrhoid, that is the external. You're not going to get a thrombosed hernia or hemorrhoid from internal hemorrhoids. Okay, it's going to be external, which we'll talk about. But external are somatically innervated, so those are the ones that really cause you pain. Okay. And we need some sort of anesthesia when we do those procedures. So in terms of that, like we're not going to ban external hemorrhoids because that would be extremely, extremely painful. Okay. So most common symptoms: bleeding, protrusion, pruritus, pain. Bleeding is the most common cause. It's like painless bright red blood. It could be on the tissue, it could be in the water. Please remember that when it's in the water, like toilet water, as soon as it's kind of like in that water, it looks more than what it actually is. So people can get very scared and very anxious with the amount of blood that's in the toilet. But most of the time it's not that much. In advanced stages, it can become significant. You do want to try to quantify how much it is, but once it's like in the water, it's very, very hard to quantify. Okay. Not overt red or hemorrhoids, but you have to consider this in your differentials. Okay. Acute thrombosis, internal, external hemorrhoids. I've really not seen it internally. You guys are going to see it more externally. And those are the ones that you guys can take care of in the clinic. Most of them are going to be in severe pain with the external. The internal, you guys probably won't see. Okay, hematochezia and iron deficiency anemias. If you have both of those, think cancer. We can do anoscopies and proctosigmoidoscopies if we want to look a little bit further in there. Proctosigs are not something that you guys are like primary care is normally credentialed to do, but anoscopies absolutely. This is an anoscope. Okay, it's clear. You lube it up. It's kind of just like a speculum for the vaginal exams. It doesn't duck bill like a gynecological speculum, but you lube it up, you stick it in, you take out the internal structure, and you can see through the entire thing to see if you see any internal type things. Okay, we still want to do that careful digital exam to make sure that we're actually feeling hemorrhoids versus a mass. All right, so grading. Okay, I want you guys to know this, because when you refer these to general surgery, we want to know what grade it is. Okay, grade 1 is you have a little bit of bleeding, no tissue prolapse out of the anus. Okay, these are internal hemorrhoids, no prolapse. Okay, you just have bleeding. Type 2 is when they're actually having a bowel movement, or when they Valsalva, they do have that tissue actually going past, like, over the dentate line and outside the body. Okay, but as soon as that bowel movement is done, it spontaneously reduces back up into the colon, up into the rectum. Okay. Type 3 is it prolapses, but you need some digital manipulation to get it back up there. Okay. And then type 4 is it is stuck down there. No matter how much you try to manually reduce it, it's not going to go anywhere. It is stuck outside the body. Okay. Thrombosis, you have that clot within. Like I said, most of the time you're going to see these in the external hemorrhoids. Okay. And there is no grading for external hemorrhoids. It's just external. So internal has the gradings 1 through 4. External are just external. Okay, and it's either they're there or they're thrombosed. If you saw this picture, that is a thrombosed external hemorrhoid. Okay, it's like a little pearl on the outside of the rectum, outside of the anus. Sorry, anus, not rectum. Okay. So, medical treatment. This is nothing new. You want to do stool softeners. Goal is to do large soft stools. You can do Colace, Metamucil, any type of softener. I would not, this is not a laxative, right? This is like an osmotic type deal. We want to try to increase the water and fiber into the stool so that it's not rock hard. Okay. Sitz pass, so if they have some external or prolactin internal hemorrhoids, right, we can do sitz pass. It's like warm water. Most of the time it at least helps with pain and itching. Doesn't necessarily do anything in terms of like helping reduce the hemorrhoid or anything like that. It's just kind of helping keep it clean, very clean, as well as sometimes helping reduce the pain and itching. Okay. Topical anesthetics, the lidocaine jelly is great. Nitroglycerin type ointment and calcium channel blocker ointments are great. Anti-inflammatory wipes, the preparation H wipes, sometimes witch hazel is sometimes used, and realistically it's patient education, okay? When you refer to general surgery, they should have tried all of this, okay? They need to be on fiber for at least 6 weeks, most surgeons will say, okay? Unless it is in like a grade 4 hernia that just keeps bleeding, it's causing a lot of pain. They need to have tried stool softeners. They need to have tried the fiber, kind of tried and failed the ointments before we really go and do a hemorrhoidectomy. A hemorrhoidectomy is probably one of the most, from what I've heard from patients, it's one of the most painful experiences they've ever done. Okay, so the risks really have to, or like the benefits really have to outweigh the risks. Okay, so non-surgical treatments, we have sclerotherapy. Okay, endoscopy, we identify those hemorrhoidal complexes, the internal ones, and then we instill like a sealant type of solution in them, and hopefully that will reduce them. Banding, most of the time this is done in clinic. I've seen this done. It's, they use a special kind of tool to grab, so they do like an endoscopy type deal, or at least a anoscope kind of speculum exam where they can see that internal hemorrhoid, and they basically either use a vacuum to suck it up into this little device and then they band around the base, or they have this, this is more old school, where it's a little metal ring. They take some forceps, pull up the hemorrhoid, and then that ring kind of releases that band at the base, okay? If we have a lot of rectal pain, fever, inability to void, meaning, fecal avoidance, right? Really early antibiotic, we want to do aggressive surgical drainage. So post-banding sepsis is a rare complication that can be fatal. So this is something that if you're gonna do banding, which I don't think primary care is really gonna do, you're really gonna send these to a general surgeon. And they'll do them and they'll do the consult, but knowing that you do have complications that you can have with banding, it's not although it's more non-invasive, it is still a very, it's a procedure that can lead to death, right, if it's not done correctly and followed correctly. All right, so surgical treatment. So excisional hemorrhoidectomies, we do this in the OR, okay, we have internal or mixed hemorrhoids. Risks, you can have, if we take too much, we get through the muscle, you can have incontinence, you can have strictures of that muscle, okay, so either fecal incontinence or inability to actually go. It is, like I said, probably the most severe pain post-operatively that I have ever encountered with patients, okay? While you're under anesthesia, normally general anesthesia, they go in and old school, they would cold knife it, and when I say cold, it's just the knife. They basically pick up the hemorrhoid and they cut it and then they sew it, the skin, to get the hemorrhoid off. Nowadays, they are more so under heat. There's this special tool that we use. Basically, you still pick it up with forceps. You put this clamp on there, it heats up, and then cauterizes it at the base, and then cuts it, and then we can take it off. Okay. Still, both are extremely, extremely painful, and it takes a while for the area to heal. If we do excisional hemorrhoidectomies, we're only doing one hemorrhoid at a time. So if all three hemorrhoid cushions are diseased, they may have to do this 3 times, which most of the time after we do one, they're like, no, never again, I'm not going through that ever again, okay? Because the last thing we want is to do all 3 and then not like either the whole thing strictures or they are like, it's way too much of like a complication risk, so we normally do 1 at a time, depending on which one is the most diseased, okay? So, when we're talking about acutely thrombosed external hemorrhoids, we do these in the clinic, okay? They're not truly hemorrhoids. Basically, it's that external hemorrhoid that has that collection of blood that, I mean, it is a true hemorrhoid, but not really, depending on what book you look at. You're just removing that clot, okay? It's excisional removal of the clot, okay? You're not like excising it like an abscess or an EIC. You're literally around the base of the external hemorrhoid. You're just taking the whole thing off, the skin and everything, okay? It'll be a little bit of an open wound until it heals, but we do sitz baths, we do very good education on keeping the area clean. They may have to shower after every bowel movement or at least do some sort of cleansing. But you can kind of see from that picture, like we're taking that entire lesion, okay? We're not just opening up that skin, taking the clot out, and then having, just a linear incision. We're taking that entire thrombosed area off. Does that make sense? Yes, I'm getting a little bit of shaking heads. Okay, good. I do ask this on the test. Okay. because I need you guys to know the difference of which ones you can do in clinic and which ones you can't. Okay, this is something that's going to be a credential that you guys will be able to do. So knowing which ones you guys can do in the clinic versus not, you need to know that difference. All right, rectal prolapse.
Damn.
Yeah. So rectal prudencentia is a full thickness, so the entire rectum is basically protrudes out the anus. Okay, rectal prolapse. It prolapses outside the body. You guys have probably seen this, definitely in GI, but kind of the same thing when you talk about like the ureteral, like your the uterus prolapse, right, or the bladder prolapse. It's basically the entire organ, which in this case is the rectum, prolapses outside the body. Okay, a lot of times it's from constipation, female sex. Unfortunately, why do you guys think that?
After there's
Loss of supportive structures due to? No, not menopause.
babies.
Babies. Okay. So it's not just because of the female. Like if a female has never had babies, it's just as likely as a male to get this. Okay, unless they're all Olympic lifters, right? Those are the types of people. Postmenopausal status, because of that loss of function, that loss of tissue strength, and then any other previous rectal surgeries. Okay, eccentric, circumferential folds of the rectal mucosa. There really is not much of like an ideal procedure to fix this. To have you guys talked about this in EM on like the acute treatment of rectal prolapses yet? Sugar. Sugar. Don't use salt. Sugar. Sugar will help decrease that fluid within that tissue, so hopefully you can manually reduce it back up. Okay. But after you reduce it, you should try to do something. Okay. If you can't, then we'll still do a pexy of some sort to keep it up from prolapsing again. Depending on whether we do a rectal approach or an abdominal approach, really depends on if the sugar works or not, or what other kind of diseases they have in the area, that kind of thing. It's really surgeon and patient specific on which approach they're going to do, but it does the same thing. It basically, if they couldn't get it reduced, it'll either pull it up or push it up under general anesthesia and then tack it so that it doesn't happen again from the inside. All right, fissures. You will see this. Okay, so these are not fistulas. These are small tears, so fissures, small tear in the anal canal, distal to the dentate line. Okay, so the same regions as your external hemorrhoids. 90% of them are posterior. 90% of them are posterior. And posterior meaning to your back. Okay? A lot of them are in women. Constipation, diarrhea, straining, heavy lifting can all cause fissures. If you see fissures that are in multiple locations, right? So if you are trying to pass a large stool because you've been constipated, most of the time it's just going to, if you're going to tear, it's just going to tear posterior. Okay? But if you kind of look and you're like, man, there are tears everywhere, you got to think that there's most likely another thing that's happening. Something else, whether it's UC or Crohn's or something, is causing that tissue to become very friable and very fragile. Okay. Acute tears are more small tears, usually medically treated, resolved within 4 to 6 months or 4 to 6 weeks. They are painful, right? Kind of treat them the same. We can use some lidocaine jelly. Sometimes nitroglycerin type ointments sometimes help. Sitz baths are really good, and just keeping the area clean. Giving them stool softeners and really even some laxatives, osmotic laxatives like Miralax, will help keep their. You want to basically treat their constipation so that they're not constantly putting stress on this tear, and it either gets bigger or it just never heals, turning into a chronic fissure, okay? When you have chronic fissures, you're gonna have more likely, or if they've had, acute on chronic fissures, meaning you have a fissure, it heals, then they get constipated again, it gets another fissure in the same spot. So if you have multiple over your lifetime, you're gonna have more sentinel tags, world mucosal edges, the anal papilla may be hypertrophied. So when you do a DRE on these patients, one, be very, very careful because it is going to hurt. They most likely will not let you do a DRE for acute or chronic, okay? But chronic ones are less likely to heal with medical management. Most of the time, if you have a chronic fissure, it's just not gonna heal medically, and we have to do something to try to fix it, okay? So, like I said, acute pain after the passage of stool, most likely constipated type stool, okay? You're having sharp tearing, searing pain that lasts a few minutes, may have hours throbbing pain. If it's chronic, they may, kind of like that, other diseases where if you do something that causes pain, they may not eat as much, right? So they may be a little malnourished because they don't want to have a bowel movement, or they may have like a liquid diet that they're on. So having that conversation with them is really important. Kind of mimics hemorrhoids in terms of symptomology, painful, they may bleed. Like I said before, internal hemorrhoids rarely cause pain, but fissures are pain. They cause pain. So like I said, nitroglycerin or nifedipine, so a calcium channel blocker, ointment, are the most successful conservative measures that we have. We can nowadays start use like a Botox injection to try to help relax that sphincter, so it's not as tight. It's not going to cause that tear to get worse. But that's really if the other two ointments don't work. And then operative management is a lateral internal anal sphincterotomy. Okay, we don't want to. They already have a tear posteriorly. Okay, so we're not going to make that tear worse by doing the sphincterotomy at that location. Okay, it's already torn. That's not going to help them, and most likely it's going to cause what we call a keyhole anomaly or abnormality, where it just never heals, and now they have their rectum or their anus and then a V. Okay, you're going to have a lot of fecal incontinence. It just does not work. Okay, so they have the fissure posteriorly. We're going to cut one of the lateral sides of the sphincter. Okay, so what that does, it allows that posterior to heal while then still allowing that lateral portion to have a little bit of flexibility. Okay, that lateral side will heal eventually as well, but given that now we're having that lateral side be able to stretch, that's allowing that posterior side to heal. Does that make sense? Okay. So we're not going to cut the posterior side where it's already fissured. We're going to cut the lateral sides to help with that stretch. Okay? All right. Moving on to fistulas. Okay? Fistulas are tracts within the tissue. We have many different locations in which we can have them. Crohn's and UC both can cause fistulas. There's a lot of things that can cause fistulas, but basically it's an abnormal tract through the tissues from some sort of chronic inflammation and or infection. Okay, knowing where that fistula goes, whether it's extrasphincteric, suprasphincteric, transsphincteric. Okay, I'm not going to say the rest. Submucosal, right? It really just depends on where it's running in relation to the sphincter. Okay, whether it's through the sphincter, outside the sphincter, medial to the sphincter, okay, that rectal sphincter. Just that all depends. Okay, So, like I just said, where it is depends on the relationship to the sphincter, right? Intersphincteric and transsphincteric are the most common, right? So, transsphincteric right through the middle. Intersphincteric is kind of more through, like, so it goes, the transsphincteric goes straight through it, inside to outside, versus transsphincteric kind of runs through the middle of the muscle, like the muscle belly to the outside. I know that kind of sounds the same, but it's not. Okay. Anytime you see something that may be a fistula, like you are seeing, you're doing your rectal exam visually, and you see kind of maybe some pits on the outside, you really should be having that patient evaluated by a surgeon. Okay. There's a lot of sphincter saving techniques that we can do to help reduce the risk of fecal incontinence in the future. Okay, we're trying to save that muscle so that so that patient doesn't just lose control of their bowel movements altogether. Okay. 30 to 60% of fistulas develop from an anorectal abscess. So we'll talk about abscesses next, but a good deal of them, if you have someone who starts with an abscess, always have this in your mind that, hey, most likely 60% of the time they're going to develop a fistula because of it. Okay, so it's just a complication that we see due to abscesses. Okay, so what do we do for fistulas? We do some perianal drainage. You're going to have perianal drainage. You're going to have abscess, pain, itching. It is associated with Crohn's and the IBDs. Okay. Diagnosis is really made by anoscope or proctoscope. We must find an internal opening. It can't just be the pit on the outside. It has to have an opening connecting into the rectum, okay, above that dentate line. We gotta figure out the anatomy. Like most of the time we're gonna do this in the OR with trying to find that fistula tract so that we can exactly see how we're gonna treat it, okay. The biggest thing is marsupialization of the fistula tract. So once we have that tract identified, we're going to use the special tool and kind of go up into that tract and basically scrub the shit out of it so it becomes raw. We want it open and raw, okay, on the inside of that tract. Then we put this kind of a rubber band that's got two ends, so it's not like a band, but it's, think of like a rubber band, it's a surgical band, that we then kind of put through that fistula. One end comes out of the anus, the other side is coming outside of the tract. We tie it together, and that is a seton placement, okay? What that is that this band is inside this now raw tract. A lot of inflammation is going to happen, and every 2 to 4 weeks, that surgeon is going to tighten that band. Okay, and what that is it's trying to get that tract to heal and get close to the skin. It's kind of trying to move that tract, and as it heals, move that band so that by the time it's done, that tract is no longer there. Kind of always trying to close down that circumference of the tract. Does that make sense? This is a little kind of convoluted and a little hard to explain if you haven't seen it. But this is a good representation, right? You have that abscess, you have that fistula going through and above that dentate line. So this is that rubber band, okay? Every 4 to 6 weeks, they're gonna tighten that, and basically what that's doing is causing that fistula to move until it's no longer there, okay? Wound care when this seton is placed is really sits fast, dressing changes, trying to prevent the constipation, so softer stools, that kind of thing. Unfortunately, if you have any service members who have this in place, it is non-deployable, okay? If they have a fistula and they have a seton in place, they are non-deployable, okay? So when you're doing your pre-deployment workups, make sure that they don't have anything weird, okay? And that is because they require numerous follow-ups, continuous treatment, continuous tightening of that band, so that by the time it's, that fistula is healed, it's no longer there. It's basically, we're trying to gradually move that tract through the skin until it's no longer present. Okay? If you have questions on that, we can talk about it after. So, talking about abscesses, okay? There's a lot of different regions in which you can have abscesses. The four main common ones are dependent on where they are in relation to certain muscles and sphincters. Okay? Perianal and ischiorrectal. Okay, so perianal is next to the anal sphincter. Okay, it is the furthest or the most superficial one that we have. Okay? If we have ischiorrectal, then that is next to the rectal sphincter. When we have intersphincteric and supralevator, intersphincteric is inside that sphincter, okay? And supralevator is super deep above the levator ani muscle. Okay, so it's all in relation to the muscle of the pelvic floor and the sphincter of the anus and rectum. Okay. When we have perianal and ischiorrectal, okay, they're outside that sphincter, they're more superficial. We can treat these in the office, in the ED. Depending on how deep they go, we may have to go to the OR. But if they're relatively small and they don't go that deep, you can treat these with IND and packing in your office. Okay. When they're more internal, like if they start internal, if they're inside the muscle, inside the sphincter or above that muscle, we have to take them to the OR. Okay, these are not something you guys should be trying to deal with in the clinic. One, if it's inside the sphincter, we want to try to do sphincter sparing techniques in order to try to spare that sphincter, right? We want to, the whole point of treatment of these and anything perianal, perirectal is trying to prevent fecal incontinence in the future. That's what we're trying to prevent, okay? So if it's outside the muscles, you guys should be able to take care of those, as long as they don't extend deep into the pelvic cavity, okay? But once they get internal, you really have to take them to the OR for surgical treatment. You're gonna have to most likely do a CT, MRI in order to find them, okay? And when we do EUA, so exam under anesthesia, that is in the OR, they are under general anesthesia and they are completely relaxed, and we can actually then look inside their rectum and do their basically their rectal exam while they're asleep, okay? EUAs are very, very common in the general surgery world for hemorrhoids, for anything butt stuff. Anytime we're doing a butt stuff case, like, we're most likely going to do an EUA, because it's especially those that have a lot of pain, because they just won't let us touch them. They won't even let us look. Right? They're in so much pain, they just don't want us to even like come near them. They're not going to sit. They're most likely going to be either on one cheek, or they're going to be laying down or standing. Okay, they're in that much pain. Put them asleep, and do the exam under anesthesia. Figure out what's going on. Okay, ischiorrectal, we kind of talked about these, right? So they're more external, but lateral, okay? Going to be tender, fluctuant mass or fullness lateral to the anal canal and DRE, so you're actually going to do the DRE and you're going to feel it. Most of the time, and again, if you see these, you should still probably do a CT of the pelvis to see how far extensive it is, okay? Just because it's a little thing on the surface doesn't mean that it isn't huge inside. Think of it more like an iceberg, right? You can only see the tip. You really should do some evaluation before you potentially get into trouble doing an IND in the clinic. Okay. Now, if they're not in that much pain and it's already been draining, throw a ultrasound on it. See how deep it goes. Okay. If you can't see the end of that abscess, send them to the ER. Okay. But if you can, it's just a little, dime-sized thing or quarter-sized thing, and you feel confident that it's not within the muscle, it's really lateral to it, sure, IND it. Make sure you have good follow-up, good patient education on how to keep it clean. It can produce horseshoes, okay? So one side may actually wrap around the rectum and anus, around that sphincter, right? And you can actually have it be very deep and actually go around it, called a horseshoe, okay? Which again, if you see that, send them to a surgeon and most likely ER at that point so that the surgeon can be consulted to the emergency room. All right, perianal abscesses, very, very superficial. Okay, they're gonna have pain, fever, potentially fever. They may have erythema, they may have a fluctuant mass, but you're not gonna necessarily feel it on GRE. It's very superficial, okay? Those you can absolutely take care of in your clinic. The little IND, clean it up. You may have to pack it, depending on how big it is. If at any point in time, any of these abscesses are like, you just aren't comfortable with them, send them to the ER, right? Then the ER docs will take care of it, or they'll get a CT, figure out how deep it is, and consult the surgeon for you, okay? But if you feel pretty confident, it's very, very small, you can it's mobile, do a DRE, it does not extend into the canal at all, you're most likely fine to do that IND in your clinic. Okay. Now we are talking about those. So surgical drainage. So ischial-rectal and perianal. Yeah, like I said, clinic ED or OR, depends on how deep they are. This is just a drainage. After the drainage, they may heal spontaneously, they may not, but may reoccur. If it reoccurs, you're going to find a fistula. If it doesn't heal, think of a chronic draining fistula. Okay. For reoccurrence, as many as 50%. Okay. Horseshoe abscesses increase that fistulization from 18 to 50. So if you don't have a horseshoe, you're most likely 18% going to have a fistula. For recurrent abscesses, if it is a horseshoe, it can be up to 50%. So half of those patients with horseshoes will fistulize. Okay. Unless you have significant cellulitis, okay, you just have the little abscess and the surrounding area isn't hot, red, warm, tender, doesn't look like cellulitis, most of the time, as long as you drain it, that's source control. You don't need antibiotics. Okay, you've gotten rid of that amount of purulent fluid inside the abscess. They're gonna pack it. That's source control. Source control is great in surgery. Okay, but as soon as you start having spread of that infection into the surrounding tissues, no IND is going to cure cellulitis. That means if the infection is down to the cellular level, okay, you're gonna have that not fluctuant but indurated skin around it. It's going to be very red, warm to the touch. It may be tender, but it's going to be harder than a fluctuant. Okay, you're going to have your abscess in the middle, and then where that cellulitis is, that tissue is going to be harder because that infection is now into the tissues. We sometimes see this if that patient has tried to drain it on their own. Okay, or it's been there a while, or they have immunocompromised states like they're diabetic. If it is cellulitic, then you have to give them oral antibiotics, and if it's bad enough, then we may have to admit them and do IV antibiotics for a while. Okay, we're still going to get source control with the IND, but you really have to treat that cellulitis if it's there. But if it's not, you don't have to do antibiotics. Source control is just fine. And then, just like with everything else, pain meds, stool softeners, laxatives, and then perianal hygiene. Okay, education. Okay, pilonidal disease. What time is it? Has it been 30 to 50 minutes? 4 more minutes? Okay, we'll try to get through pilonidal disease, 4 more minutes. All right, so pilonidal is subcutaneous infection originating in the gluteal cleft, so in the butt crease, okay, in between the two butt cheeks, If it's outside the two butt cheeks, it is not pilonidal disease. Okay? It has to be cleft. Right? Cheek seat disease, that is an old school term. We saw this a lot from people being sedentary, sitting on the seats. Hair follicles, okay, in the gluteal cleft become infected with keratin, resulting in a local infection and abscess formation. See this a lot with young Quercetet men. So hairy butts, okay? Unfortunately, if you got a hairy butt, you're more at risk of this. Okay, swelling, you may have drainage in and around the gluteal cleft. You will have these pits. So everybody sees where the cleft is, right? That's the middle of the butt cheek. But you see these pits, right? Everybody see those black dots? Okay? Those are the entrances of the pilonidal disease. So in that goes deep and can visualize internally to either connect to each other or starting there, going out and then having abscesses in the cheeks or the surrounding area. But the pit is always, the start of it is always in the middle. Okay? So you might, if they're not in in an acute episode, you might just see these pits. That's it. They may not have any abscesses at the time. You still want to refer them to dermatology at some point to do laser hair removal. Get rid of the offending thing that if you don't have any hair, most likely then you're not going to have as much of an issue. Okay. Adrenitis suppurativa, or HS, can mimic PD. If you have a history of chronic carbuncles and furuncles and boils and all of the things, it may mimic HS. So sometimes it's very hard to differentiate the two, but you won't necessarily have pits with HS. And it's most likely going to be, HS is most likely going to be in like the axilla, the groin, the perineum, rather than in the butt crease itself. Okay? It's going to be more so in your sweat gland areas than in the middle of your cheeks. Okay? So sometimes it's hard to differentiate the two though. So for treatment, conservative therapy is normally how we start. Okay, INDing them in the clinic if we need to. So if someone comes to you with pilonidal disease, don't get afraid that you need to just send them to a surgeon or send them to a surgeon, right? If it's something that you can IND, there's not a lot of structures underneath that you're going to hurt because it's over the sacrum. Okay? On that note, take 10 and we'll finish up this one when we get up.
That's what it is. Yeah, that was. Is it? Is it good? That video that girl was on the monster drink? I was like 06 and he was upside down. I would have messed. You know what I'm talking about? Fucking messed up. Is that for like year four? Or is it just
You guys know the front.
Yeah. What did you do?
She's like, I haven't done this. Oh. And I'm like, oh my god, this is like something else. So, you know, I might be like the guy was next to me, he's like, oh my god.
That one I screwed up. I got the draw. Yeah. No. I had a game yeah. Yeah, no, I have to, we gotta deal with
You guys would definitely.
I guess I could download PDFs. I literally can't. Like, I'm trying so hard to read sentences, and I'm like, I'll read it again, and then lost it again.
I can't do it. I have to put on like my neighbor like has a dog that barks like at least once.
So I'm just
The
whole hour's gone.
It's crazy. Like, so I'll literally text you. I'll be like, hey, like your dog's been barking for the last 3 minutes. She'll be like, and then they'll send someone over and she'll stop for like an hour, maybe 2 hours. So I got these AirPod Maxes and I just while I'm listening, I just turn on the noise canceling and and that's the only way I can study.
She leaves her dog. Separation anxiety dog.
She's
back to the eyes.
she's a med student at FAMC. She's in residency, so like she has like really weird hours. And it's like literally most of the time Riley's fine, but like it's the day before every test. I'm like, I don't know if I just noticed this because I'm locked in and there's no sound, or if like just every time. Yeah, and it's always around. Like, 7:30.
So I only have like 20-ish more slides on this one, so let's download Spleen. It's only 17 slides. Hopefully we can get 40 slides done in the next hour. And then, I mean, normally I go through 30 to 40 in an hour anyway. So let's try to get through most of Spleen. That means only 3 and some change tomorrow versus 4. So download this Spleen one. Should be the last one, the 8th one. Okay? While you're doing that, we're gonna talk more about pilonidal disease, so we don't get behind. Okay? So, like we talked about, you know, if they come to you with a fluctuant abscess, you know, don't just send them to a surgeon, right? Actually treat the abscess with an IND, okay? Don't make them sit in pain and potentially having that abscess get worse. Alright, so do the IND, pack it, and then send to a surgeon, and or if you really truly do not feel comfortable, INDing an abscess, which by the time you leave phase 2 and become full-fledged PAs, everybody in here should be very comfortable and confident in doing INDs. Okay, so if it's not draining, drain it and refer to general surgery. Okay. We want to try to do the least invasive methods first. Unfortunately, these do reoccur, leading us to radical type surgical treatments. The old school, so basically if it's greater than 5 centimeters or reoccurrent, may include loculated type segments, so sending to the ED for general surgery to help maybe treat these best in the OR. So historically we would do what we called the shark bite excision. Basically we go in, we take basically just take the entire diseased tissue out. Left very big wounds, very painful wounds. It got rid of the tracks and rid of the disease, but it always healed very, very slowly, and led to a lot of complications. They're not deployable during this time. They basically have this huge open wound over the sacrum, right? So that's not normally the standard of care anymore. Normally we try to do what's called a BASAM cleft lift. So we still are removing all that diseased tissue, but we kind of marsupial some of the tissue and kind of make a flap over the area, so we're not leaving that area exposed and open, we're covering it with skin. Okay. Still has its complications, it can break down, it can, depending on if the tissue was really inflamed and infected, it may not have a lot of, it may break down and just still be a secondary intention type wound. But when we avoid those midline closures, so instead of bringing it together and suturing it in the middle, making kind of a new cleft, we bring that tissue over, and so now their cleft per se is lateral to where their original cleft is. Okay, so we're taking all that tissue out, all that diseased, abscessed, fistulized tissue, taking stuff from one side, healthy tissue, and actually covering it and attaching it to the other side. Okay, so it's covering that entire defect. Okay. So if there's no gluteal cleft, there's no pilonidal disease. That's basically what we're doing. We're trying to remove that gluteal cleft. All right, so primary care responsibilities when you have acute disease versus when you refer to general surgery. So acute disease, right, you IND the abscess, you provide local wound care, proper hygiene, antibiotics for immunocompromised or cellulitic type processes. These don't really become cellulitic because it's really well contained within these fistulas, within these pits. Not very often does it become abscessed or cellulitic. Non-operative management, like we talked about, sending them to dermatology for hair removal. They can sometimes do the phenol injections into these pits to try to kind of sclerose them down. But most of the time, you're going to still send to general surgery for doing some sort of either excision or some sort of massive radical reconstruction, basically, of their butt, of the cheeks. Okay? So I'm not necessarily going to have you really remember, all of the different types of surgical treatments we have, but know the acute stuff, okay? And for any recurrent, and really anybody with if he thinks of pilonidal, they should see a surgeon, right? They should see dermatology, whether it's abscessed or not. But especially if they come to you and they're like, yeah, this is my 5th time, even my 2nd time having an abscess right in the middle, you should send to general surgery because they're going to become recurrent and they're going to need surgical treatment. Okay, but you can go in and try to kind of marsupialize those tracks, but that never really gets rid of it. Really getting rid of that tissue that whole area of tissue and trying to do some sort of a flap or a lift to close down that space is really what's needed for true here. All right, rectal foreign bodies. We can't talk about the butt unless we talk about foreign bodies. So rectum is not a straight tube, right? It kind of retroflexes and retrogrades into a posterior curve, and then goes into the sigmoid, which is S-shaped, right? Once it kind of gets past that pelvic floor, things just get sucked in. Okay. Once it gets beyond that anal canal, it's really hard to get stuff out. You can kind of see in this first picture where you have something that's up there, and then they thought, I'm going to use tongs in order to try to get it out. Well, the tongs didn't come out either.
Oh, yeah.
So they had to go to surgery to relax everything and try to get it out. Okay. Most can be removed in the ED with perianal, basically regional anesthesia. Okay, you're doing a regional block. That's enough to get those muscles, the pelvic floor, to relax so that we can open up the anus and the rectum and try to grab things. But if we can't get that, or they're just too anxious, they won't relax, then we're going to go to the OR. That should be EUA, not EUS, sorry. It's an EUA, exam under anesthesia, not an endoscopic ultrasound. Okay, EUA, my apologies. I don't know how many times I've taught that. So EUA, we want to do the exam under anesthesia, okay? Once we really, we put a tube in their throat, we paralyze them, they're no longer having that guarding, that involuntary pucker, right? We can really try to relax everything and get it out. If we still can't get it out, we're gonna have to do an X-lap and get it out from the inside, okay? If there's glass, if it's like a glass bottle, mason jar, if it's a light bulb, very low threshold to just take them to the OR and get them really under anesthesia so that it doesn't break. Okay. The last thing you want is glass shards in your rectum. Okay. All right. Moving on to colorectal cancers. Third in both incidence and mortality, happens more so in the later decades of life for both men and women. Most significant risk factors are considered non-modifiable, so like age, but eating red processed meat, smoking, alcohol are those modifiable risk factors that you should be able to counsel your patients on, hey, maybe eat one less steak a month or a week or whatever, right? Adenomas are the most common, but we do want to make sure the subtype, because, so when we do the colonoscopies and we're taking off these polyps, right, we're looking for basically these subtypes. Tubular villus, and villus subtypes. Within these subtypes, villus adenomas, 40% of them, so almost half of the population will progress to colon cancer. Okay? So if you have a villus subtype of a polyp, they should probably go see a surgeon. Right? They're most likely going to have more or will progress into, whether or not you took the whole thing or not, that area will most likely progress into colorectal cancer. So non-neoplastic, 90% of colon polyps are non-neoplastic. They are benign, they're just little polyps, nothing we need to do other than take them off and get the path on them to make sure that they are still non-neoplastic. Okay? But when we get those neoplastic polyps and adenomas, we really need to figure out what they are. Histology, location, shape, size. So the Haggett classification really will kind of give you an idea of, if it's a 0, they're intermucosal, there's, in situ versus a 4, you have, carcinoma invading into the submucosal bowel, blah, 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 okay? So the higher the Hague classification, the worse the prognosis, okay? So when you have a tubobilious and bilious histology and the size is greater than 1 centimeter, those are your 2 greatest risk factors. You want to do a complete excision, so polypectomy, with a margin of at least 2 millimeters. They're going to do more frequent colonoscopies, so instead of every other year or a year, maybe every 3 months. And if we can't do, so say we take that margin, right, that 2 millimeter margin, and the cancer is all the way up to the edge of that margin, then we're going to go in and most likely do a colectomy, some sort of colectomy, okay? Because we're not going to be able to take enough mucosa before we actually then perforate, so we might as well just take that portion, okay? So that's why we send every polyp to pathology, okay? So when we're doing colon cancer screening, this should not be the first time you see this, okay? Tier 1 is our most preferred, so you can kind of see that, colonoscopy every 10 years, or the FIT test, the fecal immunochemical test, those are like the send in stool samples, I forget the common name of the Cologuard, thank you, that's that, okay? So those are tier 1, right? Those are people who have no risk of colorectal cancers. They have no advanced adenomas and first degree relatives. You normally start at between 45 or 50, okay? Depending on what agency you are using as your reference. The US TFPS likes aging, or starting the screening at age 50. American Cancer Society says we should start at age 45. Okay, so it really just depends which one you're using. I think for the majority of the military, we go for 50 unless you have other risk factors, even minor ones. Like say you have a first degree relative of who has colorectal cancer, but they were diagnosed after the age of 60, maybe start at 45 versus 50. Okay. When you're going down, so if you do have a colorectal cancer in a first degree relative and they were diagnosed before the age of 60, your patient should be doing colonoscopies, not FIT tests, actual colonoscopies every 5 years. Okay? And that is either starting at the age of 40 or 10 years before that family member's age at onset. So if they were 40 when they were diagnosed with colorectal cancer, that your patient should start at 30. Okay, and go every 5 years. All of the rest of the other 3 are, so like the familiar adenomatous polyposis, those are the thousands of polyps, millions of polyps in the colon, right? It is impossible to remove them all, okay? And you can't if you can't remove them all, then you don't know what 10% of them could be cancerous. So most of the time they do a colectomy, a total colectomy. Okay, get rid of the polyps, get rid of the colon, you have no more polyps, therefore no colon cancer. Okay? So it's not necessarily the polypopus, the FAP, basically it's we can't test every single polyp when 10% of them could be cancerous. Okay. And then Lynch syndrome, genetic or clinical diagnosis, you really should do a colonoscopy every 1 to 2 years. Same thing, starting at the age of 20 to 25, 10 years before the colorectal cancer in that family member, whichever is earlier. You already learned what Lynch disease is, I'm not gonna go over it, I'm not gonna test on it, okay? And then ulcerative colitis and Crohn's, colonoscopy with biopsies every 1 to 2 years, and that is not necessarily because you see your Crohn's develops cancer, it's because, remember, our internal gut does not like being inflamed, it does not like being that chronic infection and that kind of thing. So you can have cellular changes when you have chronic inflammation, okay? So because of that, we treat them as if, basically we want to just know we want to do biopsies every 1 to 2 years, just to ensure that we're not missing something. Okay. If you're going off the American Cancer Society, these are low risk patients, so either CT, cholograph every 5 years, sigmoidoscopy every 5, or colonoscopy every 10. This is average risk, right? Low risk, the normal person who has no family history. Every those, I will be very, very specific on which one I'm asking about. More than likely, it's going to be the USGFPS with the tiered system. Okay. So most cause, like I said, colon cancer, most common cause of colon obstruction in adults. Left-sided versus right-sided. So right-sided is colorectal cancer. Okay. Right-sided is just colon cancer. There is no rectal. Okay. So when you have left-sided, you're going to have the hematochezia. You're going to have obstruction. You're going to have pencil-thin stools. Okay. At that point, your stool has to go through this obstruction, this mechanical external compression type deal, so your stools are going to be pencil thin. Versus right-sided, you're going to have more blood loss anemia, so acute anemia. You might still have hematochezia, but you're going to have that right-sided palpable mass, potentially, okay? And because it's on the right side, when the stool then reconstitutes further up and further distally, it doesn't end up being pencil thin by the time it exits. Okay. And when you have actual rectal cancer, you're going to have the hematochezia, the trismusness, and potentially, if you feel it on DRE, you'll feel it most likely in the pouch Douglas. So, all right, you have a 61-year-old male with 2 months history of altered bowel habits, blood in the stool, pencil thin stools. Which of the following is most likely diagnosis? Who disagrees with 3? Good. Colorectal. All right. So diagnosis, right? What are we going to do? So labs, we're going to look for that iron deficiency. We're going to look for liver and kidney function. We're going to do that CEA, okay? Now, the CEA is not for diagnosis, okay? We don't do any tumor markers for any cancers in surgery, okay, for diagnosis. We still do them at diagnosis because then we look for recurrence. So after we've done the surgical resection, the CEA and like the chemo, radiation, whatever, and the CEA goes back down to 0, every time they come in to do a, like their follow-up, their 3 or 6 month or 1 year follow-up, we're gonna get another CEA, okay? If it's high, they have recurrence. So we're not doing it for diagnosis, we're doing it for recurrence. Okay, so we still get a baseline to see if their body has actually any response to that tumor marker, okay? And how high it got the first time, okay? But we don't normally use it for diagnosis, we do it for recurrence. Okay, so for staging, we want to base it on history, physical, endoscopic findings, whether that is most likely colonoscopy. Okay, and the biopsy results. If a colonoscopy cannot be completed, most likely going to do that CT colonograph or an air contrast barium enema. Okay, we can do MRIs now as well. Staging, again, chest x-ray, you know, basically all the things that we want to see if we are looking for the spread of that disease. How much has it invaded into the other spaces? We're going to do a PET to look to see if it's spread to like the lungs, the brain, right? And then we're going to refer to surgery. Okay, we can't leave these without a surgical referral. All right, which of the following is the best diagnostic study for colorectal cancer? Who wants CEA? Who wants 2, 3, 4?
Yes.
Yep, colonoscopy. Okay, cancer tumor staging, TMN, right? Same international, it's the same, right? Stage 1 tumors can hypothetically be cured with local excision of the portion, okay? You know, it's confined to the mucosa, it's basically cancer in situ, or it just involves the submucosa, okay? If it gets past invades past that wall, okay, so it's no longer contained within the mucosa, submucosa, and it's now attached to anything outside of the colon, it's gonna be harder to treat. But if it's stage one, any of the stage ones, we can potentially, right, just take out that portion. It hasn't spread to the lymph nodes, it hasn't spread to any of the surrounding pelvic structures. So we take out that offending mass of the offending intestine, and most likely we're done. Okay? So curative removes all the nodes, all the tumor. Prior to metastasis, palliative, we're trying to just decrease that tumor burden. Right? Decrease that belly pain, decrease the belly rigidity, decrease, being able to avoid those obstructions. Okay, we want to make sure we're looking at the liver and the lung. Those are the two main metastasite sites. Okay, so colon cancer loves the lung and the liver. If these tumors are relatively small and solitary, we can sometimes remove them from these locations, but most of the time, once it's metastasized, it is harder to treat. Okay, we'll do neoadjuvant radiation and chemotherapy. And like I said before, the patients with familial polyposis, we're going to do that colectomy that we're going to consider, right? We're going to have that patient education, patient surgeon, risk benefits talk to see if a total colectomy is worth it, right? If they don't want to have that constant anxiety of I have so many polyps, I may end up with colon cancer one day. Just take out the colon. Therefore, if you don't have the colon, you don't have the polyps. You don't have the cancer. Okay. So I'll just cut. All right. So this is more so a rogue memorization. Okay. It deals with when you're talking about when you're like saying a right hemicolectomy, what are we actually taking? Okay. It's all knowing like the right side and hemicolectomy meaning portion, right? So the right portion of the right side normally means cecum and part of the ascending colon. Okay, when we do an extended right, we do that plus up to the hepatic flexure. When we do an extended right or transverse colectomy, starts at the cecum, goes all the way up and takes the transverse colon as well. When we talk about left hemicolectomy, that's really just the splenic flexure, okay? Because then it goes into the sigmoid, and that's not a sigmoidectomy. So left hemicolectomy is really just the splenic flexure, so some of the descending and some of the transverse. When we're doing an extended left, that includes more of the transverse or the sigmoid. Okay. And then when we say sigmoidectomy or sigmoid colectomy, we're taking the sigmoid. Okay, so really this is rote memorization of anatomy and what the words mean. All right, so depending on, like for rectal cancer, there's two things that we can potentially do. It really depends on how much we're going to resect, whether it's high, low, or ultra low anterior resections. It really just depends on how far up we go and what structures we're going to take in terms of like the sigmoid and stuff. And then the abdominal perineal resection APR, this actually takes a lot more. So this is taking the anus, the rectum, part of the perineum, okay, and then all of the rectum, basically that anterior resection plus all of the distal structures, okay? So at this point, they're going to end up, we're not going to reconstruct the anus and rectum, okay? We're basically taking away, for lack of a better term, butthole, okay? We're taking that away completely. We're surgically removing all of it, and they're going to get a colostomy, okay? There's no real great way to say that, okay? So yeah, so we're taking all of it. Basically, they're going to be sewn shut, and they're not going to have a butthole anymore. Their butthole is going to be on the side of their stomach, side of their abdomen. Okay, there is no way of reconstructing that. There's no way of reversing that after we take these structures. Okay, but if we do an anterior resection, it is still really hard to connect that disc or that proximal sigmoid down to the anus. Most of the time, these are left with just the anus, and they're going to have a colostomy. Okay, these are colorectal surgeons have come a long way, and I'm not part of colorectal teams, so I'm not sure if they're, reattaching those at any point. But most of the time they're not. So this distal portion of the distal or the descending colon is going to come up to the stomach or to the stomach wall, right, to the abdominal wall. They're going to make a colostomy and be done. Okay. All right. Which of the following is the best curative treatment for a patient with stage 1 colorectal cancer? Anybody disagree with surgery? Good. All right, malignant neoplasms of the anal margin. Okay, these are most likely squamous cell cancers. They're well differentiated, indolent. They rarely metastasize distally. Okay, you're going to look like rolled everted edges with a central ulceration. They may present with pain, bleeding, pruritus. They may have trismus, and they may be incontinent. Okay, management. If it's an early thing, we can do wide local excision. We're going to do chemoradiation for poorly differentiated tumors, and we're going to do the APR, just basically remove as much as we need to get clean margins. Say that we do like a wide local recision or excision and it recurs, they're more likely going to then go to an APR where we're just going to take everything versus doing another wide local excision. Okay, so they basically do one local excision first if it's low grade or low stage. Do chemoradiation, see how they do. If it reoccurs, there's only so much tissue down there, right? So the more we take, the more likely they're going to end up with an APR. Okay, if it's a carcinoid tumor, remember they're endocrine type tumors. Okay, you're going to have the hot flashes, bronchospasms, arrhythmias. They get by in that carcinoid syndrome. Likelihood of distant disease with these. So if it's less than 1 centimeter in size, risk is like 2%. If it's 1 to 2 centimeters in size, you might have 50% incidence of lymph nodes. So it may 50% of the time it'll spread to the lymph nodes. And then if it's greater than 2, you're going to have 80% of positive nodes, so meaning it has metastasized. Okay, it has progressed. Okay. All right, which of the following diagnostic procedures is most commonly used to detect and evaluate polyps? How do we detect and evaluate polyps? Who wants 4? Who wants 3? Who wants 2? 1. Yes, 3. Colonoscopy. Okay? Detect and evaluate. Right? We can't evaluate a polyp. We can't do a pathology. We can't do a tissue thing unless we take it. All right. Any questions on large bowel things? No? Great. Let's move now to spleen. Was everybody able to download it? Was there anybody who wasn't able to download it? No? Okay, good. Alright, so those are your objectives. So spleen, right? Physiological functions. We started kind of figuring out what it did in the 1900s. Still didn't really know what it did until like the 20th century. Has very specific immunological functions. We are not here to do any of that. So, accessory spleens can lead to persistent disease if unrecognized. Okay, especially during a splenectomy, right? If you have someone who has ICP and they're trying to do a splenectomy to remove that, you have a little splenule or a accessory spleen, meaning you have more than one spleen. If we don't take all of that splenic tissue out, it's not going to cure the disease that we did the splenectomy for. Okay, so you have to look for those splenules and the different accessory spleens to make sure that we get them all. Okay, 75% are located within the splenic hilum. Splenic size can vary greatly depending on the disease. It may not have enlarged at all, it may be very small, it really just depends. Sickle cell anemias are really associated with the majority of like the recurrent infarctions of the spleen, okay? When we're looking at major functions, we have hematologic and immunologic. So red pulp, hematologic, white pulp is production of the immunoglobulins, that's important, okay? And the marginal zone, the macrophages and B cells. So immunoglobulins, what do they do? I know it's late. Try to stay with me, we have like 10 more minutes. Right, so like your vaccines, right? It helps your body build that response, that immune response to fight a virus or an infection, whatever, right? Macrophages and B cells. Back. You should have learned this in hemoc, right? They eat the things, eat the badness, okay? So the spleen does a lot. And if we take it out, we have to make sure that we can protect them against certain bugs that they no longer can fight against. Okay. So how do we find splenic type things? For labs, we want to do CBC. Okay, we're looking for an acute, or we're trying to identify those anemias, thrombocytopenias, thrombocytosis, looking at the reticulocytes. Okay, if we need to know certain splenic diagnoses, sometimes we have to do that hemoglobin electrophoresis. I don't think I've ever done ordered that, unless I was may have done once. Ordered that once when I was in Yuma, looking for like a thalassemia or something weird. Otherwise, I'm sending them to hemoc. Imaging, we can see it on ultrasound, great. CT abdomen, chest X-ray. So that remember with the X-rays, you're not going to see pathology, you're not going to see specifics, but you may see it enlarged. Okay, and if you see it enlarged, it looks weird, looks different, get the CT. Okay, so the X-ray is not going to give you any real diagnostic anything other than, oh shit, things are not where they're supposed to be. We need a better image to really figure out what's going on. So get the CT and pelvis. And even with CT and pelvises, sometimes we really don't know. So sometimes we have to get an MRI to really look at the vasculature, really look at the little fine details of what's going on. Okay, so there's a difference between hypersplenism and splenomegaly. Okay, splenomegaly is enlarged. It actually physically gets bigger. But with hypersplenism, you have increased splenic function. So it may not be enlarged, actually physically, literally, but the function is still acting as if it is enlarged. Okay. When we have splenomegaly, you're looking for that mononucleosis, Epstein-Barr virus, okay, or like T-cell lymphoma. When it's hypersplenism, maybe you're looking for pancytopenia, maybe you're looking for some of those weird splenic function diseases that we're not going to even talk about in here. Basically for surgery, hemoc will just be like, hey, this needs to come out. Cool, we're going to take it out. Right? I don't really need to know the diagnosis. Some we do. Right? But most of the time if we're going to do a splenectomy, they just tell us, hey, it needs to come out. Alright. Grades of splenic trauma. Why is this important?
Know how much to cut.
The number one reason why surgeons take out spleens, probably trauma. Something happened. It is protected up against the rib cage, but it's one of the more common injuries that we see. So we'll do this again with the abdominal trauma lecture in the next block, but just to kind of give you an idea, if you have a little laceration or like a subcapsular hematoma, that's a grade 1, all the way through grade 5, right, is a shattered spleen. Okay, and the reason why I say this is because if you have a shattered spleen and we go in and do a splenectomy, okay, we may not get all of the pieces. If we don't get all of the splenic tissue, they can actually then grow and develop into accessory spleens or splenules. Okay, so if you have somebody who has a history of splenectomies and now they're showing signs of like weird spleen type diseases, like ITP, probably probably should look for spondules, okay, because we probably didn't get all of the tissue out, because it was just shattered into a million pieces, and there's only so much we can do. We can, clamp and ligate the vessels, try to clean out as much as we can, but most of the time we can't get it all. Alright, so medical diagnosis is the most common reason for splenectomy, right? Whether it's just symptomatic relief of splenomegaly, secondary to chronic illnesses, like I said, ITP. Now, this is really important. ITP is one of the real ones that we need to know the diagnosis for beforehand, okay? We have to give them daily prednisone in order to bring down their platelet count, okay? And then once their platelet count is normal, then we can do the splenectomy, okay? If we do this before we treat them with the steroid, then the prednisone, we are going to cause more issues than we would like, okay? So that's the one, ITP is the one thing that we need to know the diagnosis of so we can treat beforehand. For trauma, okay, we can either take it out diagnostic or for laparoscopically or during an XLAP. If it's a ruptured spleen, we're most likely gonna go XLAP versus diagnostic lap. Okay, blunt trauma is the biggest one. Okay, so you have blunt trauma plus diffuse peritonitis, hemodynamically unstable. Okay, if it's a low grade, like 1, 2, potentially 3, we could sometimes get away with just watching it, okay, just observing, as long as they're hemodynamically stable. Okay, but once they get into like 4, even sometimes like higher grade 3s, 4s, and 5s, we have to do something, or else, because if you look back here, right, once you get into 4s, you start getting into the vasculature, and that's not gonna just stop bleeding on its own, more than likely, okay? And when you have massive disruption of that parenchyma, it's basically the capsule's now destroyed, it's going through the main vasculature within the organ, okay? It's most likely just not gonna stop on its own, we have to do something. So, a lot of times we'll do like, if it's a lower grade, like 3, sometimes 4, we can do the IR with angiography and embolization. If that does not work, we'll have to go in and just surgically remove it. And then with grade 5s, if we have IR in the building and they are hemodynamically stable, then we can do IR first and see if we can just completely ligate the splenic artery and vein. It really depends on how quick that IR can get up and get that patient in there. If they at any point start to become unstable or a transient responder to blood, we're going to take the OR and just take it out. Okay. Now for kids, we really try to not take kids' spleen. We really try not to. Or if we really try to do an embolization if possible. So like you're only taking half of you're only, embolizing half the spleen versus the entire spleen. Why do you think we don't want to take kids' spleens completely if we can try not to? What's that? Sorry, this Sahara Desert fog thing, I don't know, it's getting me. So what did you say? More so infections. Right? Like if you, what did you say again? One of the comments like killing me.
He said infection risk.
Infection, yes, sorry. Yes, infection risk, yes. Sorry, this it's 5 o'clock for me too, guys, okay? So yes, it increases the infection risk, right? If they no longer have the spleen, then they have more of their life without that ability to protect themselves, okay? So every attempt is made to keep the spleen in kids if we can. Let's see. Okay, a few more minutes. So in terms of non-op failures, okay, these are people who've tried to do non-op and they fail, okay? So here in this first picture, we have that nice arrow sign pointing to that nice bright spot in the middle of the spleen. That is a extravasation of contrast into the middle of the spleen, therefore it is still bleeding. We're gonna take that out, or at least we're gonna try to embolize that bleeder, okay? This is basically the pelvis, so abdominal hemorrhage extending into the pelvis, okay? Means that spleen has ruptured to the point of now your pelvis and lower belly is full of blood. And then on this last one, you see the vasculature, but then you see this like cloud-like structure on the side. That's the extravasation of contrast under IR. Okay? So you see that clouding, so you have nice, crisp vessels and then that clouding. Okay, that cloud is the contrast and the blood leaving that torn artery inside the spleen. Okay, alright. 21-year-old male is brought to the emergency room after being struck in the left chest with a baseball bat. Clinical suspicion is for high splenic injury, or is high for a splenic injury. Presence of which of the following is most likely to indicate an alternative diagnosis. So which one of those is going to tell you, or potentially suggest that it's not the spleen that is injured? Air under the diaphragm, right? The spleen is not an aerodigestive thing. If you have air in your belly, it did not come from the spleen. Okay? That always suggests something that is part of the digestive tract. Okay? Alright. So, splenectomy, when we're doing in the elective setting, we're most likely going to do it under laparoscopic conditions. Okay? If we're doing open, it's most likely done through a exploratory laparotomy, like a modified one, so we won't necessarily go all the way down. If we're just going into this side, we may do a little one, like above the belly button, so that we can get over here, but we're not necessarily doing all of it. Okay? If we end up doing open, they're more associated with transfusion requirements, longer lengths of stay, higher morbidity. So we try to do laparoscopic if possible. Either way, no matter which one we're doing, we're isolating the spleen, finding that splenic hilum. We're going to clamp and then ligate the artery first. Okay. What that does is that the spleen, being highly vascularized, right, is where the blood gets filtered. If the artery is then cut, so no more blood is going into it, but the vein still allows it to drain. Okay, we're still allowing all the blood in the spleen to drain into the splenic vein, and then once we have the spleen will actually turn a little bit of a lighter color once it's all drained, and then we can ligate the vein. Okay, if we do both, and say it's one of those huge ass splenomegaly, then that's a lot of blood that is potentially in there that patient could use, because it's their own blood. Right, so if we allow it to drain, it's kind of like an auto transfusion of what blood's already in there. It just goes back into the patient before we ligate the vein. Okay, we ligate as close to the spleen as possible because of the fact that it is super close to the stomach and the pancreas, the short gastrics and the caudal pancreatic artery and the pancreatic tail are the tail really of the pancreas is probably one of the most commonly associated complications because when we take it out, the tail runs the length of the splenic artery and kind of then sits like the tail ends in the splenic hilum. Okay, so we try to make sure that we're not getting any of that when we do the pancreas lecture tomorrow. We try not to fuck with the pancreas. That is our one, if we had any rule in surgery, is don't fuck with the pancreas. Okay, we don't want to touch it, we don't want to look at it, because most of the time then something goes wrong. Okay, the pancreas is one of the most finicky things, other than the brain, like it's the most finicky thing we have in our belly. So, say we do clip a little bit of that pancreas, okay, when we're taking out the spleen. even if we took a millimeter, it's gonna drain into the belly in that area. All the pancreatic juices, okay? The pancreatic juices that digest food, right? You're gonna have a lot of issues in that area, okay? So if we already know that the pancreas, that tail is super abutted to the spleen, more than likely we're gonna try not cut into that pancreas, but we're gonna leave it drain, okay? Because we're gonna try to catch all of that pancreatic drainage before it then erodes and breaks down our vessel ligations that we did, okay? That's, if we didn't leave that drain, right, and there's a lot of digestive juices now, or right over where we tied off those vessels are going to break down and they're going to bleed, okay? So these people normally stay in the hospital for at least a day. They don't go home that next day, or at least they're in the hospital for a minute, okay? Because we really want to make sure that they're not going to have any complications being where it is. Okay. Now, there's different things in which we can do to try to, if we're not going to necessarily do a splenectomy, right? Splenectomy is the complete removal of the spleen. We can do a splenography, okay? That is basically taking that rough edge or that damaged edge and try to repair it rather than remove it, okay? I have never seen a splenography, okay? If it's damaged enough, we're just gonna take it. I've never seen a surgeon, there are probably some out there, but I've never seen a surgeon try to save portions of the spleen, okay? It does happen, I just have never seen it, okay? And that's really for mild injuries, right? And who potentially respond to bleeding and resuscitation, we can do that splenography, okay? If they have any active hemorrhage, they're hypotensive, coagulopathic, acidotic, hypothermic, we're gonna do the splenectomy and or the IR for embolization if there's time. Okay. Now, hyalogenic abscesses. This is something, say we have a subcapsular hematoma from a stab wound or a bullet wound. That capsule kind of coagulated on itself and it's not an open, but now you have a collection of blood gonna get infected. It's gonna end up being a hyalogenic abscess, okay? Abscess within the spleen. Really? Alright, fine. We'll finish hyalogenic abscesses tomorrow. Have a good night. We have 5 slides left.